Hello everyone and welcome again. So continuing our discussion about the orthopedic trauma basic principles class. Now we are going to move more to the clinical side, and before we talk about the management of fractures, here we will talk about the management of the injured patient or the trauma patient in general. So here we will discuss the trauma systems, and we will focus on the ATLS system, and we will talk about the airway, the breathing, circulation, disability, exposure, and then we will talk about the trauma films, and finally we will talk about the orthopedics trauma management. So let's start. Let's start by talking about the trauma systems. Now, after the patient gets injured, you need to do the critical procedures required for them to stay alive. And those procedures are ordered in the trauma system in the order of the most important to the less important. So when you start using, or when you first receive your patient, you will start with the critical points first, and then you do the less critical points last. And that's what trauma system is about. It orders those procedures in that way. So you do those critical procedures, and then you manage their fractures and less critical injuries after that. So there are systems for that, including the ATLS, that's the famous one, developed by American College of Surgeons, and which we will here. But also there is other systems like the BHTLS and the ETC, depending on your institution and what system they follow. So let's talk about the ATLS, the Advanced Trauma Life Support System. So ATLS contains three sections: the primary survey, the resuscitation, and the secondary survey. The primary survey is rapid assessment of the patient using the ABCDE. The A stands for airway and cervical spine control, the B stands for breathing, then circulation and hemorrhage control, the D is for disability, and the E for exposure and environment. So basically, you start in order to evaluate each of those. You start with the airway, then breathing, then circulation, then disability, and then exposure. So let's first talk about the airway. So the airway is the first thing assessed to the injured patient, and it is done even before attending or being carried on the ambulance in some systems. So the airway is assessed for patency. If the patient is talking or screaming, then the airway is patent at the moment, but noisy or absent breath sounds suggest compromised airway. Immediate interventions for the airway include many, including the head tilt and chin lift or the jaw thrust in the comatose patients, suctioning relief airway compromise in many patients, and use of oropharyngeal and nasopharyngeal airway may be necessary. And you can search each of those interventions on YouTube just to have an idea about it. So sometimes the immediate interventions are enough, but other times the patient still can't breathe, and that's when the patient needs an advanced airway. So this is the head tilt and chin lift. So basically, you tilt the head using this hand right here, and the chin is lifted by the other hand. And here we have the jaw thrust. So basically, you put the fingers on each side of the jaw, and you try to raise it up just to relieve the obstruction done by the patient's tongue. That's one way to do it. So here we have the oropharyngeal airway, and here is how it looks when it is inserted. Basically, And here we have the nasopharyngeal airway. Now let's talk about the advanced airway. So in the advanced airway, we have multiple types. We have the orotracheal and the nasotracheal intubation, and both of those are non-operative. And if those failed, then cricothyroidotomy and emergency tracheostomy needed. And both of those are operative. And you can search each of those on YouTube just to have an idea. So indications of advanced airway include many. The first is the patient is being apneic, they can't breathe. The second is that the inability to protect the airway, and that's when the Glasgow coma scale of the patient is less than 8, and we will discuss the Glasgow coma scale in further slides. And when the patient is having impending airway compromise in cases of inhalation injury, that's when the patient inhalated smoke or chemical compounds, and those will lead to the airway being compromised, but eventually after a while. So you would expect that, and you would do an advanced airway to the patient. And neck penetrating injuries like those would lead to hematoma formation and the pressure on the airway, and extensive subcut air in the neck, and inability to maintain oxygenation by the patient, meaning when you calculate their SpO2, you find out that they can't maintain the optimal levels, so you would do an advanced airway for them. So this is a picture for the orotracheal intubation. This type of intubation is the more common one. It's used in the surgeries and it's more common in general. So this is the orotracheal tube, and here we have it being done on the mannequin. So remember, with the airway comes the cervical spine control. So in the A there is airway and cervical spine control. So cervical spine control, all patients with the blunt trauma require cervical spine immobilization until injury to the cervical spine is excluded bilateral X-ray of the neck. Immobilization achieved by semi-rigid cervical collar, like Philadelphia collar for example, or placing sandbags on both sides of the head, and the forehead is taped across the bags. So soft collars are not effective. We only use semi-rigid cervical collars, and in penetrating neck wounds, the cervical collars not recommended because they interfere with the treatment. So you can search the cervical collars on Google and see the types and differences between them. So this is example for the cervical collar. This is Philadelphia collar. It looked like that. So after the A comes the B, which stands for breathing. So it is the second priority after the airway, and all trauma patients should receive high flow oxygen and monitored by pulse oximetry. And you should watch for chest movement on examination. You should watch that the chest movement are equal on both sides. So rapid evaluation for life-threatening injuries, chest injuries like tension pneumothorax, open pneumothorax, massive hemothorax, and flail chest. And after breathing comes the circulation, that's the C in the ATLS. So initially palpate the pulses to check for the cardiovascular system status. If you palpate the carotid pulse, the systolic blood pressure of the patient is 60. And if you palpate the femoral pulse, and if the femoral pulse is palpable, the systolic blood pressure of the patient is 70. And if the radial pulse is palpable, then the systolic blood pressure of the patient is 80. So blood pressure measurement gives you idea about the grade of the hypovolemia if the patient is hypovolemic. Hypotension, when the systolic blood pressure is less than 90, assume that it is caused by hemorrhage until proven otherwise, in trauma patient generally. And here we have the grades of the hypovolemic shock. So we have 4 grades: grade 1, grade 2, grade 3, and grade 4. And here we have, the first one is blood loss in milliliter and percentage. So in grade 1 it is up to 750, which is less than 15%. In grade 2 from 750 to 1500, which is from 15 to 30%. And in grade 3 from 1500 to 2000, which is from 30 to 40%. And in grade 4 it is more than 2000, which is more than 40%. The pulse for grade 1 is it's less than 100. In grade 2 is from 100 to 120. Grade 3 from 120 to 140. And grade 4 is more than 140. The blood pressure is normal for the first 2 grades, and it is decreased in the last 2. The pulse pressure is normal or increased in the first one, and in the last 3 is decreased. The respiratory rate is in grade 1 from 14 to 20, grade 2 from 20 to 30, grade 3 from 30 to 40, and in grade 4 is more than 35. The urine output is in grade 1 is more than 30 milliliter per hour, and in grade 2 is 20 to 30, in grade 3 55 to 15, and in grade 4 is negligible. And the mental status, in grade 1 the patient is slightly anxious, in grade 2 is mildly anxious, in grade 3 the patient is confused, and grade 4 the patient is lethargic. So in circulation you place 2 large bore IV cannulas, and blood should be drawn before starting resuscitation with fluids to prevent RBC cross-linking and agglutination, which will affect the test result. So blood is drawn for cross-matching, bedside hemoglobin level and trauma panel, coagulation panel, ABG for base deficit. So we mentioned that the patient needs 2 IV cannulas from the large bore type. So we have multiple types, and each of them have different color to point for this type of cannula. So starting with yellow, it has the least flow rate, and ending with orange, which has the highest flow rate. And the last 3 are considered large bore. So in circulation, there is also rapid evaluation for massive hemothorax, cardiac tamponade, massive hemoperitoneum, and mechanically unstable pelvic fractures with bleeding. So now let's talk about the hemorrhage control. So start with manual compression with a single gauze and a gloved hand. And the bleeding of the extremities might be managed with tourniquets for the short term. And open fractures bleeding is controlled by reduction and stabilization of the fracture with splints. And the pelvis should be stabilized with a sheet or a binder to limit the bleeding. Let's talk about the fluid resuscitation. So the best resuscitation is achieved with the blood, but that is not usually ready until later. So start with isotonic crystalloids, typically Ringer's lactate, which is superior to the normal saline because the normal saline lead to hyperchloremic acidosis. And in massive transfusion, we give packed RBCs, platelets, and fresh frozen plasma in a ratio of 1 to 1 to 1, meaning 1 bacterial RBC pint, 1 platelet, and 1 fresh frozen plasma. And you aim for hypotensive resuscitation systolic pressure target of about 100 in bleeding patients, and that's to protect the clot that has formed and thus decrease bleeding. Because once you raise the systolic blood pressure more than 100, the clots that are already formed, they would dislodge and they would lead to further bleeding. And you assess your patient by monitoring the vitals. Those include the pulse, blood pressure, respiratory rate, SpO2, and urine output. And you also monitor by labs, which include the hemoglobin, the coagulation profile, the lactate, and the base deficit. So now let's talk about the lethal triad. So the lethal triad is the three physiological abnormalities indicating inadequate resuscitation and increased risk of death. The first one is coagulopathy. That's when the platelets is less than 120 and the INR is more than 1.5. So coagulopathy because of consumption of clotting factors, and it's solved by using platelets and fresh frozen plasma as early as possible in the resuscitation. The second one is the hypothermia, which is when the body temperature is less than 35, and that's from exposure to cold and from fluid resuscitation and lead to impaired enzyme-dependent pathways, including clotting. The third factor is the acidosis, and that's when the pH is less than 7.25, and it is because there is inadequate oxygenations from the respiratory failure or respiratory acidosis or inadequate peripheral tissue hypoperfusion. So after the C, which is the circulation, comes the D, which stands for disability. So neurologic evaluation include the level of consciousness, which is either the patient is conscious, drowsy, confused, stuporous, or comatose. Also, evaluation for the pupil size and reactivity to light and motor function. So common causes of the neurological deficits in trauma include the head injury, hypoxia, shock, alcohol, or drug intake. Assessment of disability is either by the AVPU scale or the Glasgow Coma scale. The AVPU stands for the A, awake, the V, response to verbal, the P is response to pain, and the U is unresponsive. And the AVPU scale is real simple. It's just the patient is either awake, response to verbal, response to pain, or unresponsive. The Glasgow Coma scale is more complicated, and here we have the adult Glasgow Coma scale. The pediatrics have a slightly different one than the adult one. You can Google that, but here we will explain the adult Glasgow Coma scale. So the score, so we have three different things in the Glasgow Coma scale: the eye opening, the verbal response of the patient, and the motor response, and each one given a score. So the eye opening, if the eye is not open and can't be open, the patient is given 1 point. If it is open to pain, 2 points, open to voice, 3 points, and open spontaneously is 4 points. The verbal response, if there is none, it is 1 point. If there is incomprehensible sounds like moaning, the patient takes 2 points. Inappropriate words, random, the patient gets 3 points. And if the patient is confused or disoriented, get 4 points. And if the patient is oriented, get 5 points. In motor response, if there is no motor response, the patient gets 1. If there is extensor posturing, the patient gets 2. If there is flexor posturing, the patient gets 3 points. If there is withdrawal in response to pain, the patient gets 4 points. And if there is localized pain, or the patient can localize pain, he gets 5 points. And if the patient follow commands, gets 6 points. So Glasgow Coma scale interpretation. So after you assign each of the types and you give points to them, you add them together. And so when Glasgow Coma scale applied to head trauma patients, so if the patients have a Glasgow Coma scale of 13 to 15, it is considered as a mild injury. If it's from 9 to 12, moderate injury, and if it is from 3 to 8, is severe injury which require intubation. So after the disability comes the exposure and the environment. So all clothes of trauma patient are removed using scissors in order to make sure to examine all body parts from head to toe for trauma, and keep the body warm using blankets to prevent hypothermia. And hypothermia is used only in cases of severe brain injury to save the rest of the brain that are not injured. So after the primary survey and resuscitation comes the secondary survey, and it is head-to-toe examination of the patient. You basically examine every system, and there is a mnemonic, which is sample to things that you look for in a trauma patient in the secondary survey. The S stands for signs and symptoms of the patient, so you look for those. The A for allergies, the M for medications, past medical history, last meal, when and what, and the event history. So now let's talk about the trauma films. So in blunt trauma, you send the patient for lateral cervical spine x-ray plus erect AP chest x-ray and plus AP pelvis x-ray. In penetrating trauma, you send all of the above and plus the x-ray for the site of injury. And you also send, in both of those, you send the patient for EFAST and you send the patient for RUSH, which is rapid ultrasound for shock and hypertension. And finally, let's talk about the orthopedics trauma management. So recovery from orthopedics trauma is done by stabilizing the injuries. And early total care is definitive stabilization of all long bone fractures within 24 hours of the injury if the patient is stable within that period. If the early total care can't be done, there's the damage control surgery. So it is the immediate surgery that is required to save the life and limb of the patient when the patient is unable to undergo early total care. So other procedures delayed until the patient's condition is improved. So we basically do damage control surgery until the patient condition is improved, then we do the total care. So damage control surgery include stabilization of the unstable fractures, including the pelvis, the femur, the vertebrae, and also includes decontamination of the open wounds, amputation, and decompression of limb compartments. And patient should undergo as much of their surgery as is safe, as soon as they are physiologically able to cope with that surgery. So basically, there is a mix of those two. You do damage control surgery and you do some of the early total care as much as the patient can undergo, or as much as that is safe for the patient. And with that, we reach the end of this video. So the future videos will talk about the management of fractures. And yeah, thank you for watching. Please make sure to like and subscribe. And if you want to support more, you can by subscribing to the Patreon, link provided in the description of this page. Thank you for watching and see you in the next videos. Peace.